Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is December 3rd, 2025. This video is on a Lancet article published online last week, November 27, 2025, titled Heart Failure with Reduced Ejection Fraction, a seminar. What defines heart failure with reduced ejection fraction, or HFrEF? It's an ejection fraction equal to or less than 40%, characterized by reduced systolic function. What symptoms are typical in HFrEF? Shortness of breath, orthopnea, bendopnea, fatigue, edema, and reduced exercise tolerance are common. How is HFrEF diagnosed? Diagnosis requires symptoms, elevated natriuretic peptides, and imaging confirming reduced LV systolic function. Which biomarkers help rule out heart failure? An NT-proBNP less than 125 picograms per ml or a BNP less than 35 strongly argues against heart failure, negative predictive value. What imaging is first line? TTE, transthoracic echo, is the primary imaging modality for assessing structure and LV ejection fraction. Why is rapid initiation of GDMT important? Early treatment improves survival and reduces hospitalizations. In fact, it's important to look at door to GDMT time. What are the four foundational therapies? RAS inhibitors or RAS and ARNI, beta blockers, MRAs, that's a mineralocorticoid receptor antagonist, and SGLT2 inhibitors. What's the role of diuretics? They relieve congestion and are used for symptom control. When is ARNI preferred over ACE inhibitors? In symptomatic patients tolerating ACE inhibitors or ARB, sacubitril valsartan offers superior outcome benefits. What benefits do SGLT2 inhibitors provide? They reduce heart failure hospitalization and cardiovascular mortality across LVEF ranges, that is, across a range of LV ejection fraction. When is ivabradine used? In sinus rhythm with a heart rate equal to or greater than 70 beats per minute, despite maximally tolerated beta blockers. When is vericiguat considered? For symptomatic patients with recent decompensation despite GDMT. Do MRAs improve survival? Yes. Spironolactone and eplerenone reduce mortality and heart failure hospitalizations. What comorbidities worsen outcomes? Chronic kidney disease, iron deficiency, ischemic heart disease, and arrhythmias increase risk. How is iron deficiency managed? IV iron improves functional capacity and reduces heart failure hospitalizations. What potassium levels are ideal? Target potassium 4.5 to 5 millimoles per liter to minimize cardiac arrhythmic risk. What causes diuretic resistance? The adaptation by the nephron requiring sequential nephron blockade. Are beta blockers safe in HFrEF? Yes. Evidence shows mortality reduction despite historical concerns. Is digoxin still used? Rarely. But digoxin has shown benefit in the 2025 Digit Heart Failure trial. I did an earlier podcast on this. What device therapies are recommended? ICDs for left ventricular ejection fraction equal to or less than 35%. And cardiac resynchronization therapy for QRS equal to or greater than 130 milliseconds with symptoms. How often should patients be followed? At least every 6 months with closer follow-up during titration. What is the prognosis? Up to 50% mortality at 5 years, though modern GDMT improves survival. What is mid-range EF? LVEF of 41 to 49%, similar biology and therapeutic response to HFrEF. What lifestyle measures help? Sodium restriction, exercise, and adherence to medications. Why is adherence challenging? polypharmacy, low blood pressure, hypertension, kidney dysfunction, and clinical inertia in their implementation of GDMT. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.